and 4 deaths to date. We are preparing for more cases and more deaths in the weeks and months to come. We are learning from the experience of other provinces and around the world, and we have prepared modeling scenarios that are based on our best knowledge at this time. And Derek will walk through some of how the modeling data is being used to inform health system planning. This modeling data will continue to be updated with Saskatchewan-specific data so that we can be making decisions in real time and going forward on the best available evidence from our experience in Saskatchewan. But I think the takeaway, the models that we're using in Saskatchewan and other provinces across Canada all underscore the importance of aggressive and sustained public health measures and population health approaches to flatten the curve. And that's what I'll be talking about in my part of the presentation. Next slide, please. Our strategy that we're using for the Saskatchewan Health Authority is based on an offensive and defensive strategy. It includes strategies to contain, delay, and mitigate, and also population health promotion. The population health approach is important because it helps us look at the distribution of risk and protective factors and the direct and indirect impacts of COVID-19 across different population groups. We do know that the pandemic does involve everyone, but we also know that individuals and communities are affected in different ways. We do know that populations most at risk of severe outcomes include persons with underlying health conditions and also older adults, and they bear the disproportionate burden of illness. Even in the low-range modeling scenarios, we expect that there will be significant numbers of severe illness. We also know that healthcare workers are at risk of disease because they are both exposed to the virus in the work that they do. And we also know that healthcare workers may present a risk in terms of being infected and asymptomatically transmitting the virus onto the patients and clients and people that they interact with, and that's what we're working to prevent as well. We also know that healthcare workers experience stress of working on front lines. Our experience in Canada post-SARS showed that post-traumatic stress disorder was quite significant amongst healthcare workers. And that's also something that we need to be preparing for and supporting our healthcare workers and first responders. And indeed, we're using a definition of healthcare workers that is quite broad. So it does include those that are providing healthcare and services, but also people who are serving as first line or front line responders, including police and fire and other municipal workers. We do know that isolation and physical distancing is hard, especially for people who are already marginalized or socially isolated. So we do need to be thinking about strategies that are acknowledging those needs and making sure that we are providing supports, including where there was previously existing social supports that are being impacted, such as food banks and shelters. So that's part of our planning as well, because our goal overall is to be promoting health at the same time that we are preventing disease and ensuring that healthcare services continue to be available. Next slide, please. So some of the key strategies that we're using as part of our public health approach include increasing testing. The number here is a bit out of date. This presentation was prepared for last week, but we're over 20,000 tests performed in the province now. Increasing testing and making sure that testing is available across the province is part of our strategy to identify cases early so that we can initiate a case and contact investigation around each case. We've expanded our contact tracing capacity by more than 300% as part of our planning. We also have public health inspectors who are working to enforce the Provincial Chief Medical Health Officer orders in partnership with law enforcement. And we're also investing in new data tools to manage cases, clusters, and outbreaks. Next slide, please. So in terms of community care strategies, we have expanded our access to Healthline, which provides online assessment and responses to callers' questions with more than 250 new staff that have been trained. We are delivering more primary healthcare services through virtual care models, primary health care and specialist services with more than 750 clinicians set up to do this. And we've opened testing and assessment sites around the province. And again, this is out of date. We continue to open new testing and assessment sites each week. So we have those located around the province with more to come. Next slide, please. And in terms of population health strategies, we are looking at identifying priority populations for testing, and this includes persons who are admitted to hospital, either to ICU or for hospitalization who have symptoms of COVID-19. Other priority populations include those who are residents or who provide care in long-term care, personal care home, and other types of congregate living situations so that we can identify and respond to outbreaks earlier. And again, for the reasons that I described, healthcare workers and first responders are also a priority population for testing. We are initiating other strategies to protect healthcare workers, including continuous mask use policies, screening healthcare workers at the start of shifts for COVID-19 symptoms, and also providing supports through an occupational health and safety line, and making sure employees are aware of the supports that are provided through occupational health and employee health to support psychological health and mental wellness as well. We have initiated the screening in long-term care, and that applies not just to the healthcare workers, but in many cases, residents and visitors to the facility as well. Visitors are restricted, but allowed for compassionate reasons. We are partnering with communities and across sectors to ensure that the needs of more vulnerable populations continue to be met, and looking at strategies to support persons who are required to self-isolate or self-monitor in the community because they may be infected or have been exposed, identified as a contact to a case. And then last but not least, continuing to promote messages that address the need for health education, so promoting hand hygiene and what people can do to protect themselves and their families against COVID-19. Promoting messages for health promotion, including the need to stay strong and healthy and take care of your physical, mental, social, and spiritual health to be resilient as individuals and as a community. And then also paying attention to health equity, which looks again at the distribution of risks and burdens across population health groups so that no one is unfairly disadvantaged by the public health measures being put into place to benefit all of us. Next slide, please. So as we go forward into the rest of the month and in the weeks and months to come, we do need to remember that the public health measures need to be sustained to be effective. We also know that we need to keep learning. We need to be understanding and removing the barriers that prevent people from taking the necessary action. We do know that this pandemic will continue for weeks and months to come. We may not appreciate the whole picture or understand the full impact until it's over, but it is really important that we continue to be measuring and monitoring and tracking and learning and using the best evidence that it continues to become available, including our own experience here in Saskatchewan, to help us make the best next decision. Next slide, please. So as I described, our strategy includes both an offensive and defensive line. So our offense includes all of the things we're doing to contain and delay the transmission of the virus, and also population health promotion initiatives that strengthen our individual and community resiliency. Derek will take us through our defensive strategy next, which includes all of the things we're doing to mitigate the impact of the virus and ensure that healthcare services are available when needed. I will say that I think language does matter quite a lot. We are all playing for the same team on this. We are going to win, we're going to lose together, and we need to remember that we're all on the same side. I think we can get into trouble when we start to point fingers at individuals or across organizations or between communities. But the reality is the virus doesn't respect those types of boundaries. Everyone is at risk, and no health system in the world can withstand the pressure without sustained help from the public. We all need to do our part to prevent transmission, and we are all in this together. So I will turn it over to Derek now to take you through the next part of the presentation.
Thanks, Julie. So Julie talked about the offensive strategy in Saskatchewan. We all like football analogies, so we're hoping that we get to keep the offensive team on the field for as long as possible in this game, and that we don't have to rely on the defensive. But it is important to have a defensive strategy, and we have put a lot of effort into preparing and planning for this. So our defensive strategy really focuses on acute services, hospital services, and how we would adapt to future potential demands that arise because of COVID. We have a number of principles that we are applying as we proceed with planning and preparation for potential wave of COVID-19 positive patients requiring service. I'll just walk us through those. So obviously we need to be able to meet the care needs of the province while minimizing loss of life. And we do that by increasing the capacity to provide care within our facilities. Throughout this, it's important to also continue with our existing mandate of providing essential and urgent health services for the non-COVID positive patients in the population. We do anticipate, and we have seen disruptions to what we would consider normal health services delivery. We see this with the slowdown of elective surgeries, for example. In many cases, this may mean alternate ways of doing things, like using virtual care to deliver services that people require. Our whole entire response is based on a staged approach. So it isn't a flip the switch and everything is activated. It's as we start to see patients, the demand increases, we activate our plan and to respond to those in steps. And I'll talk about that more as we go through this. We are going to cohort COVID-19 patients as much as possible, and we may use field hospitals to support capacity where we don't have that within our existing facilities. Ethical decision-making will be needed throughout this response in all aspects, and it's based on the SHA ethical framework. We need to deploy staff and physicians to other facilities to support care, moving past, I guess, existing boundaries or understandings of where people work. And safety and infection prevention and control will guide our work throughout. We know that that's essential to keeping our staff safe and our patients safe as well. Centralized bed flow coordination will also be important. While we do have plans locally in terms of how we respond, really it's a provincial response, and we're going to coordinate the flow of patients to ensure they're getting the care they need in the spaces that are most appropriate. Slide, please. Our defensive strategy is focused on mitigation. And so a few specific things that we're doing. We do have an ongoing province-wide slowdown of non-essential and non-urgent services. And up to this date, this has freed up about 1,000 acute hospital beds so far. We also have a staged expansion plan for acute care capacity. So again, staged in terms of we would only activate this if we are seeing the demand for those spaces. This would allow us to increase and phase in about 57% more acute beds across the province than what we currently have. We also would increase intensive care beds from the 98 ICU beds we currently have to 963 beds if needed. And again, that would be a phased approach. Preservation of supplies is essential in the face of a global pandemic. There's significant demands on supplies for personal protective equipment, as well as lab supplies and other items. We are adapting a labor pool strategy where we will allow for the assignment of people to support those areas where we're surging capacity, and we would be reassigning them from areas that had experienced a slowdown, or accessing a supplementary workforce such as volunteers, students, and others. We are creating dedicated spaces to cohort COVID-19 patients. This may result in some places in the creation of designated COVID-19, non-COVID-19, and also mixed hospitals. And again, that we would only be activating those in a phased way in response to the pandemic. And then also the creation of community treatment capacity to help us respond. Slide, please. We established two planning scenarios to help us determine how much additional capacity is required. And you may have seen last week when we provided this information publicly, there were modeling scenarios built into those to that presentation where we have projected a number of different potential scenarios that allowed us to pick a capacity number that we could plan to. So we basically picked a number between a high and a mid-range modeled scenario in order to establish, okay, this is the amount of demand that we need to plan towards. And it's based on the premise that we activate that capacity as needed in response to patient demand going into the future. So we're actively planning and implementing all the preparations needed for this planned capacity level. We also identified that given experiences in other jurisdictions that there is a possibility that we could see a major spike in demand in what we might call a worst case scenario, and that we needed to have contingency plans in place to be able to surge to address that kind of situation. So we have prepared contingency capacity to address the worst case scenario, but we aren't actually activating those, or we're not actually implementing those. We have them if we need them. Next slide, please. So this slide basically walks through our existing capacity, and it includes existing capacity within the system. Just normally in some areas there is some capacity that's there, and also and more significantly the impact of the service slowdown that we've undergone over the past number of weeks. So you can see it's broken down by geographical area, and it has a total at the bottom, and it speaks to both ICU current state and acute care current state. And just drawing your attention to the ICU numbers. So we currently have capacity beyond what we need for a current average daily census of 41 ICU beds. And likewise, on the acute side, we have just over 1,000 beds capacity available beyond what we're actually using to address our average daily census. Next slide, please. We know that intensive care is a key piece to any response to COVID-19. We've seen that even in Saskatchewan with the numbers that have been admitted to hospital, that there are patients that require ICU care. So planning towards a peak in ICU patients is prudent, and we've done that here with a, you can see again the areas and the total along the bottom for the province. We have an average daily census, and then we have a peak critical care patients number, and we've broken it down by area and summarized it for the province of 833. We expect, or based on this, we don't expect, we hope this doesn't happen obviously, but we're planning towards a number of 890 potential ICU patients at the same time in this planning scenario. And based on that, we've planned for a capacity beyond that with about 963 ICU beds capacity. And you can see that there's a breakdown here between Saskatoon and Regina, which they have excess capacity beyond the numbers that are identified for their specific areas. And in the north and rural areas, they don't have enough capacity for ICU. And this is where we emphasize that this is a coordinated provincial approach. It will see critical care patients flow from rural and north into the urban centers as their capacity levels reach and maybe exceed what they're able to manage locally. But even in the very early stages to this, we are going to be moving patients around within the province to the different critical care capabilities in order to make sure that patients receive the right care in the right environment. Next slide. In terms of planned capacity for acute care, this is similar to the last slide where it depicts the breakdown of acute care beds between what we are planning now in terms of regular operations with our average daily census, what we see in the planning scenario for potential COVID-19 acute care patients, and then what that would mean at a peak. And so in this case, we see that a peak around 3,300 total acute patients. We have identified the ability within our existing facilities to surge to about 3,100 beds, which obviously falls short of what the potential peak is. And so we've identified the need to create field hospitals, one in Regina, one in Saskatoon, for a total of 650 beds to allow for us to meet and exceed that potential peak capacity. Next slide. Ventilators are an important part of this based on what we see the COVID-19 disease in other jurisdictions. We currently have across the system 450 ventilators to meet the modeled demand, what we see at the low end and up to the mid-range scenario. Our planned capacity range is actually higher than that. It's between the mid-range and the high-range scenario. And so we do have a gap of about 410 ventilators because this targeted plan capacity is 860. So we have placed a number of orders for ventilators for the province. We have confirmed orders of 200, and 100 of those are expected within the next two to 3 weeks. We are feeling pretty good in terms of the ventilator capacity of what we have right now to address immediate demand, and also what we see coming or expecting to be delivered in the next few weeks to meet and close this gap. We are working closely with the Ministry of Health and also the federal government in order to help close that gap as well. Next slide, please. I'm going to talk a little bit about the integrated health area plans at a high level anyways. I know that there have been opportunities where there has been engagement with local planning leads and the people that have been involved in preparing these, the more local plans. So again, this will just be a high level overview. Next slide, please. I've said it a number of times today, and I really want to emphasize this, especially for our community leaders out there, that this is so important to understand that this entire response is a staged approach. So we're not flipping the switch on hospitals to identify them as COVID or non-COVID or anything like that. Rather, we're going to respond based on the situation as it evolves. So we may have identified the potential through our plans here of designated a hospital as a COVID-19 hospital, but we may never get to that point of actually having to do that. We would only do it once certain trigger points have been met. I mentioned earlier the existing capacity, about 1,000 acute care beds in the system right now. We would access that existing space first before we would be activating this additional spaces. Our plan is premised on the basis of cohorting COVID-19 patients together on designated units, and then potentially as designated hospitals as COVID-19 hospitals. If a hospital is designated as a COVID-19 hospital, it would initially essentially be a mix. So again, it wouldn't be just overnight that it would just all of a sudden be a COVID-19 hospital. It would likely see a period where it had admissions for both COVID-19 patients, and they would be cohorted within an area of the facility. And then once it reached a certain point, then it would expand to encompass the whole facility. But for a period, they would likely operate as a mixed hospital and have both COVID and non-COVID patients there. There's a diagram at the bottom here, and this is just meant to demonstrate, if you look at any of the demand curves or projected peaks or anything for COVID-19, you can see that displaying with the round bell-shaped curve. And then we have our capacity steps overlaid on top of that. And the intent here is to show that, again, we're not going to the very top step just with the very first case of COVID-19. Rather, we have a stepped approach where we're going to step it up, and we're going to be stepping it up to always stay ahead of the demand that's coming next. And likewise, on the other side, we would be ramping it down with a similar approach. Okay, next slide. I'll start off with the integrated northern area. In the north, they have a staged response to increased demand through a combination of mixed and non-COVID hospitals. They don't have, there are no, we have not identified any COVID designated hospitals for the north. There are no facility closures, and field hospitals have been contemplated, but only in a contingency scenario. So we're not actively building any field hospitals for the north right now. And you can see, just based on the breakdown there, the locations of hospitals that would be mixed versus those that would be non-COVID hospitals. Next slide, please. Integrated rural health. In this area, we have planned a staged response through a combination of COVID and non-COVID facilities. There are no facility closures. We are in rural temporarily converting some hospitals to support alternate level of care patients, and this would be happening over the next 4 to 6 weeks, where we would be making this switch. What that would do, it would allow for the flow of alternate level of care patients from tertiary and regional hospitals in order to create additional capacity in those areas. And in order to consolidate staff, we would also temporarily suspend emergency department services in those 12 facilities that are identified for this. And that essentially allows us to take the nurse and the physicians that were supporting these emergency departments and bring them into areas where they would support surge capacity, and have them get trained up on all the protocols and oriented to those new working environments, so that they can successfully contribute to a surge in response. We're not planning any field hospitals in rural, because there's capacity already within the system. Next slide. Here's the map of rural, and it goes through, and many of you might have already seen this in terms of those sites that are identified as COVID patients only, or COVID hospitals, non-COVID hospitals. The yellow dots identifying long-term care that would be ALC only in terms of the hospital side, and then a number of primary care sites that have seen some service reduction. So a point to emphasize here is on facilities that are identified as COVID hospitals and non-COVID hospitals, they would still see their emergency departments remain open throughout the whole response plan. They would only, until they're actually activated as a COVID and designated as a COVID or a non-COVID hospital, they would basically continue operations as they are now in terms of their emergency department, and also through their admissions into their facilities. And then only at a certain point in time would there be a trigger of a certain level of occupancy that we would identify that this hospital is now a COVID hospital. It's only going to admit COVID patients. However, the emergency department would still be open, and that emergency department would still see all patients, COVID patients as well as non-COVID patients. Likewise, in a non-COVID hospital, they would at this point continue to see all patients. The emergency department would see all patients, and only at a certain juncture would they be designated as a non-COVID hospital. The yellow dots, the conversion of acute space to alternate level of care. Again, this stand up of this work is planned to happen over the next 4 to 6 weeks. There will be communications that would go out. As part of that would include municipal and community leaders as part of that notification process. So there would be a high level of awareness of any service disruptions that would be happening in support of this. Next slide, please. In Saskatoon, it's a staged response to increased demand, and it's using mixed hospitals that will serve both COVID and non-COVID patients. So that's across the board. We will cohort patients together on units and by floor. We are looking into the community to identify long-term care spaces that could be used to support patients that are currently in hospital. We also have a field hospital that's planned for Saskatoon, and that's actively being developed right now. Next slide. In Regina, it has a very similar response as we saw in Saskatoon. It will have mixed hospitals as well as mixed hospitals serving COVID and non-COVID patients. We will be cohorting patients within the facilities. And I'll maybe just point out that we're going to be cohorting COVID patients within a hospital that is also going to be seeing non-COVID patients. We're very aware of the risk of transmission for COVID-19 just generally, and also within our health facilities. We will be applying very stringent infection prevention and control processes to minimize the risk of transmission within these facilities. And so that is a fundamental part of our plan. So when we see mixed hospitals that will have COVID and non-COVID patients, we will be following the necessary safety processes to ensure that we minimize any risk of transmission within those facilities, the same as we do everywhere. We are accessing Wascana Rehab Center in Regina to support non-COVID patients as long as they can get the right level of care in that environment. And we're also looking into community long-term care space as another way to expand capacity for people that can appropriately receive care there. We are planning a field hospital for Regina, and that's in the works right now. Next slide. So I'll just try to wrap things up here before we open the floor. So in summary, and I'm sure many of you saw the various modeling information that was provided last week, and even across other jurisdictions and from the federal government as well. There's lots of modeling information out there. We use modeling information to inform our planning work. We looked at a number of different scenarios and potential trajectories in order to come up with something that we felt we needed to plan to, and that's what we're doing right now. We've broken our strategy into an offensive strategy and a defensive strategy. The offense really is focusing on containment and delay of the virus and flattening the curve, and we're seeing the effects of that right now. I'll emphasize here that the public has the biggest impact on the outcome of our offensive strategy, and so that's a call out to all the people that are called into this webinar, and for you to carry that into your communities. And I know that people are working hard at that. We do have a defensive strategy that contemplates the preparation of surge capacity in our acute facilities to address patient demand. We're hopeful that we don't need to activate these spaces and pursue this, but it will be there when we need it. Again, we're all in this together. The Saskatchewan Health Authority, we're all approaching this as a provincial response and working together to make sure the health system is there when you need it. We absolutely need your help with this. As Dr. Krasnowski said, no health system in the world can beat COVID-19 by itself. We need the public to really make the biggest contribution in this. So with that, I'll wrap up and I'll turn it over to Sean for our next step. This information was posted last week when we did the public announcement. I don't have the website at my fingertips, but everything is posted on the Saskatchewan.ca COVID-19 website. I just don't know exactly where it would be found on there, but we can definitely find that.
Okay, so they should be trying through their normal supply chain or their local OH&S. If that's not possible, then they should be contacting either the Saskatchewan Volunteer Firefighters Association for some assistance or they could go to the Saskatchewan Public Safety Agency. There was a meeting, town halls, 2 of them held last week, which identified a process for fire departments to request PPE through the SPSA. So that's what I would recommend that they do.
No, I think Krista covered it well. Thanks.
Are you able to hear me? Okay. Hi. Yeah, I can take that one. So at this time, we don't notify the municipalities if a person living in a community tests positive for COVID-19. Certainly, the individual is notified by public health, and that initiates a case and a contact investigation. And through that process, people may become aware that somebody in the community has tested positive. But the goal is to protect patient confidentiality and not to disclose the identity of an individual. With the Ministry of Health, we are making surveillance information public, and that does report the distribution of cases in the province in more general terms, so you can see approximately where in the province cases have been reported. I think it's really important, though, to recognize that just because cases haven't been confirmed in a community or in a region of the province where it looks like some parts of the province are more or less affected than others, testing is just the tip of the iceberg. So we do know that not all persons who have symptoms even though recommended for testing, may be tested. So it likely is an underrepresentation to some extent. So I think it's prudent to be assuming that anybody who has respiratory symptoms that might be COVID-19, that it's managed that way. So we do recommend that anyone who has respiratory symptoms is taking measures to self-isolate for the duration of those symptoms, and then to be seeking guidance from 811 and getting tested. Yeah, so certainly that has been looked at, and there have been studies that have looked at the predictive value of testing people after their symptoms of COVID-19 resolve. What we do know from those studies is that the more symptomatic you are, the more likely you are to be shedding the virus and the more infectious you are to others. So once your symptoms significantly resolve, your risk of transmission to others is diminished. So there is guidance that is based on a conservative estimate of kind of what that window of infectiousness would be. So at this point, we are recommending that people who are positive for COVID-19 continue to self-isolate for 14 days after their onset of symptoms, or until 48 hours after their symptoms significantly resolve, whatever is longer. And again, that's quite conservative. So we're very confident that persons who are self-isolating for that long and their symptoms have significantly resolved would not be infectious to others. And we don't regularly test people at the end of that period. I think there may be situations where we would consider doing that, particularly if somebody's symptoms are not resolving or getting worse. Certainly that would be a reason to be retesting somebody who has already tested positive.
Yeah, I can take that, and Julie might also want to speak to care in the home. Certainly, if somebody is positive in the home, the recommendation is for self-isolation. So for self-isolation, that is, you know, again, having your own. There are some guidelines on our COVID website that talk through the process for self-isolating, but it means that you are having, if possible, your own bathroom. You are not using the same utensils, you're cleaning surfaces, and you are staying away from others in the house. So I think that was important around then at home. We aren't recommending that there is necessarily PPE in the home, but there is a self-isolating approach. So Julie, if you want to add to that in any way.
Yeah, I'm not sure that I have much more to add. If the question pertains to, I guess, what measures persons should take in terms of self-isolating at home, I would recommend that everybody think about what their plan would be if they are required to self-isolate. And just for clarity, persons are required to self-isolate if they have symptoms of COVID-19, or certainly if they've tested positive for COVID-19, and also if they have a member of the household who has tested positive for COVID-19, then that household is considered to be close contacts, and everyone is required to self-isolate. So just thinking ahead to what your plan would be. And then if you are providing care within a household to somebody who has COVID-19, there are measures that you can take, including absolutely diligent hand hygiene and other measures to protect yourself from being exposed. So those are all things to consider as part of your household plan.
Yeah, it's Evan here. Can you hear me, Sean? Okay. So yeah, that is a good question. In terms of right now, the transportation, and depending on the acuity of the patient and the patient's needs, but there really is no change currently in terms of the transportation of patients with COVID. We're using both ground ambulance and fixed wing Saskatchewan Air ambulance and STARS rotary wing, again, depending on the what type of response is needed. As we go forward, you know, and that's part of the EMS plan in terms of the cleaning. There is some cleaning, obviously, after each, if there's a COVID patient that was transported, and we actually have we have standard work for that on that EMS is following on the Saskatchewan.ca government COVID-19 website. There are actually 3 different work standards for a post-patient ambulance clean, a surface clean, and a terminal deep clean that can be accessed. It's not a significant process, and the providers are quite efficient at it. But yeah, that would be if you're wanting to make use of that, that has been vetted through the proper channels and the infection prevention control procedures in those standard work.
Yes, so for the RCMP perspective, we wouldn't necessarily be transporting patients, but persons that have been apprehended who are suspected of having COVID-19 or displaying symptoms, we would obviously be using, the police officers themselves would use precautions and protective equipment, as well as the person would be, a mask would be put on the person to prevent further spread. And after the transport was completed, then the cleaning protocols of the vehicle would take place after that.
Sorry, just unmuting myself. There is. We do want to minimize the risk of false negative tests. So we are recommending for persons that if they can wait until 48 hours after symptom onset, that can help reduce that false negative probability. It also does give us a better sense of what those symptoms might be. So often symptoms start being a bit mild, perhaps a headache or a bit of a sore throat, or not quite sure if it's turning into something or not. But if you wait for 48 hours, it's usually quite clear that you do have symptoms that are more typical of COVID-19. And then if testing is done 48 hours after symptom onset, it's likely that we'll get a result that I guess can be interpreted in that context. That's why that 48 hours after symptom onset is recommended, but certainly we would not want anyone to be delayed seeking care if they do have more severe symptoms that require medical assessment. So waiting for 48 hours before testing is not any reason that people should not be seeking care if their symptoms are warranting that, and especially if their symptoms are getting worse.
Hi, it's Krista. I'll answer this one. We have around 1,300 medical first responders in over 250 communities. So we have some communications that are planned to go out to our medical first responders this week to outline our plan to ensure that our medical first responders can safely respond to calls during this pandemic. Our medical first responders require training in a number of areas really specific to responding to calls during a pandemic, the changes that are required in their response, how to screen patients for COVID-19, PPE, so including what PPE to use and how to properly put it on, take it off, and dispose of it. Our first responders also require PPE supplies for droplet and contact precautions. So right now what we're currently doing is we've started assessing each medical first responder group's readiness to respond to these calls safely. Once that readiness assessment is complete, we're going to be working with the medical first responder groups to complete that training and to obtain the required PPE.
Yeah, thank you, Sean. I can answer those. So this a staged response basically just speaks to the fact that we're not activating everything that we've planned overnight at the flip of a switch. We're only going to be activating it in response to increases in demand that would require us to have additional capacity. So that's what we mean when we say it's a staged response. Like for example, you're looking at a screen right now where it has COVID-19 hospitals and non-COVID hospitals. We wouldn't be activating those COVID hospitals until we actually got to a certain point of occupancy that we would designate the entire hospital as a COVID hospital and redirect non-COVID patients to other facilities. So that's the state. That's what we mean by a staged response. The 12 facilities that were identified where for conversion of the acute beds to support alternate level of care. There were a number of different considerations that were contemplated in making those decisions. Some of them were related to we need to make sure that we're able to sustain and appropriately train the staff that are in those emergency departments to be able to respond to COVID patients walking through their door, so that they would have all the capabilities to do that. And part of this is about bringing those people together in a consolidated location so they can get those skills and be able to contribute to a surge. One of the bigger drivers is creating space in other facilities like the regional and tertiary centers, and that's where we're going to be pulling those ALC patients from those other larger facilities and consolidating them into these ALC designated sites. In terms of the emergency services and the impact of a temporary suspension of emergency services in these locations, that definitely was a consideration in this planning, and certainly we're trying to balance the dangers on the other side of ensuring we have appropriate capabilities in these emergency departments to respond to COVID positive patients that might end up on their doorstep, and also about getting those people into other centers where they can get the training and orientation and everything they need to be able to address a surge in demand out of those other locations. I'm just looking, there's another piece of this question here. The timing of these. So when we announced this last week, we indicated that we would be moving forward with these changes, these temporary conversion to support alternate level of care and the associated temporary suspension of emergency services. We would be doing that sometime in the next 4 to 6 weeks, and that plan is will be phased in. And so we're working on that right now. There will be communications that will happen as part of that, and certainly with municipal leaders, you're definitely an important stakeholder in that we would be reaching out to you to advise of any changes in services as part of that process. Yeah, I would suggest that people contact SPSA on that. We haven't been closely involved in terms of providing that kind of instruction to communities, but SPSA I think would be better to be able to potentially support that.
Yeah, I would love to know that myself. Certainly with the modeling data, it is based on some assumptions about the row value. So how many people each case of COVID-19 might infect. And we can lower that row value number through the public health measures that are in place. So the physical distancing, the self-isolation, mandatory self-isolation for people with symptoms, for example, and also promoting things like hand hygiene. So with all of those measures that we have in place, we can drive that number down to below 1, which means that each case is not infecting more than any one person, and that will stop the virus's transmission, and that would be really great if we can achieve that. And if we do, then that would effectively stop the current outbreak, but we would still need to be diligent about monitoring imported cases. So whether from outside Canada or between provinces where there still is ongoing transmission. So I guess that I'm saying that I don't know what the future holds, but we're doing all the right things right now. And if we can sustain it, then it will be, I think, a better place to be in terms of the number of cases that we're seeing, but obviously the social distancing, the physical distancing and the self-isolation is really hard to sustain. So I know that the modeling group and the provincial chief medical health officer is also looking at, I guess, what might happen if some of the measures became more relaxed, and then we'd also be continuing to watch for signs of community transmission and then could implement more stringent measures. So I think we're all anticipating that we will be dealing with COVID-19 for weeks and months to come. And it is important that we adhere to the measures that are already in place. And those may change over time. They may be more relaxed or they may become more stringent again, just based on what we're seeing in terms of the epidemiology in the province. So I don't have a crystal ball, but that's kind of some of the considerations going forward.
Thank you. Really important question and point. I think one of our challenges is that information changes and is updated and we learn more on a daily, weekly basis. I would encourage everyone to use the SASC website that you've been putting on the bottom of your side, saskatchewan.ca.covid19. There's a healthcare professional section. We make sure that the healthcare professional guidelines and the information about PPE and any updates that we have go to that site. That is the source of truth, and we'll have the most updated. So if anything's been changed, it will be updated there. We also are working through as Derek talked about, the integrated health instant command centers, where information or standards that are developed provincially at the EOC are then shared out to those areas for them to share out with their staff. So we're hoping that information goes out that way, and again, information or questions come back through that to help us answer questions. We also have both a hotline for healthcare workers. It's and again, it is on our site, but it's 1-833-233-4403, and we can send that out after. And that's for any healthcare worker who has a question about PPE, about occupational health. They can call that number to get the latest guidance or information. We also have if they're part of the SHA, they can call, email, or an affiliate. It's occupational OHS healthcareworker.covid19@Sask Health Authority. Again, we can share those with you to send out. So there's a number of ways that we hope we're creating for healthcare workers, nurses, and others to both ask questions and to receive. We send out a daily bulletin with updates, and we've just launched, starting last week, a PPE bulletin that, again, is information for our healthcare workers to inform them of the latest information.
Yeah, I think that's a really, I guess, interesting question. Certainly we know people who have underlying lung disease or other health conditions would be more at risk of serious illness if they were infected with COVID-19. At this point, I'm not aware of additional measures that are being put into place to protect air quality, but that's important to be doing for other reasons as well. So I don't have, I guess, more of an answer to that, but that's one that we can take back and follow up with the Ministry of Health and other sectors that would be involved in that type of response.
Yeah, appreciate that. I see it here. It would be hard for me to comment without knowing some of the specifics, but I would say that in terms of community preparation, and it seems like this is in the north where they have some, I guess, autonomy in terms of the developing alternate patient care sites. I don't know the context, so it's difficult to comment. But I will say that from a community perspective, preparations for potential outbreaks and so on, I think that's good planning to pursue, and connecting with other jurisdictions is an important part of that, especially in our northern communities. So I'd be happy to follow up with the person who sent this if you want to connect outside of this. It's just hard to comment without the more specific details.
Yes, it's Evan here. So in EMS, we've been doing a lot of work around preparation, ramping up, and what that's going to look like in terms of flow. Been working with our facility and SHA leader colleagues to kind of determine what that looks like as well. So some of the things that we're doing are to ramp up are looking at our ambulances, ensuring that the backup ambulances are well maintained, what additional ambulances are available, and then in terms of paramedics, obviously going out to the workforce, and do know that expressing or seeing which retired paramedics or others that were in industry are looking to help during this as well, potentially help, and to get registered through the College of Paramedics. And the other piece around this is really the coordination piece of it, and how can we best coordinate those transfers and ensure that the local ambulance is able to get back to their community as quickly as possible. And again, each piece, as kind of Derek described throughout the presentation, it's depending on what phase we're in, will differ in terms of what that implementation might look like. But we do meet as an EMS group twice daily. There's the EMS Incident Command Center, and we meet twice daily, once on the lead as leads, and the other one is senior officials in the afternoon, and we go through and we talk through all these, and there's more planning to be done, again, with our colleagues in SHA.
I'm not aware of any estimates in terms of number of potential people that may be coming back to the province. I'm not sure if Julie has anything to add to that.
No, we don't have estimates of those numbers.
It's Derek here. I guess I would say to this that last week when we presented the information publicly, the media certainly provided the primary means to share information as they typically do. And so that it would be a good source for people through traditional media. But then there's also social media and other ways to get information. The SHA will be doing weekly updates every Tuesday afternoon with the media, outlining our response and progress with respect to COVID-19. And so again, media will be covering those, and updates will be available through them. And the materials that we share with the media then are then available on the Saskatchewan.ca COVID-19 website. But I guess I guess there are other locations where people might be able to get their information.
I'll respond to this one. It's Krista. So certainly, you know, looking at a pause to the program was a consideration, but we also needed to look at not every call is a COVID call, and if we were to remove those 1,300 medical first responder volunteers that provide a very valued service, most of our calls are not COVID related, so we would be potentially withholding those services from those communities in rural and remote areas. So the decision was made to continue the program and then provide the training and the PPE. One thing I would just really stress is that as volunteers, medical first responders always have that choice to respond to calls or not. And the SHA will fully support our volunteer medical first responders if they decide not to respond to calls.
As many know, the summer months can spell wildfires or floods for communities. Does the SHA have any recommendations around evacuations for communities and upholding the health guidelines and rules in conducting community evacuations?
Yeah, that's a really good question. Certainly the potential for other natural disasters or any kind of disaster, I don't think they'll be put on hold just because we're dealing with a global pandemic. So we are aware that we do need to have contingency plans in place to be able to support that. And we are working with the Ministry of Health and other government partners to ensure that we would be able to respond to any scenarios that might arise during this time.
Perfect. Thank you very much. And last but not least, I'm just looking at all these, seeing if there's one that is particularly pressing. So there's just kind of, there's still several questions regarding the temporary shutdown of emergency rooms being detrimental to local residents I just ask maybe, Patrina, if you just share some thoughts on what the SHA is doing to avoid kind of any issues. I guess Krista, Patrina, and Evan, yeah, how is the SHA going to kind of mitigate the risks in shutting down EMS services or emergency services in these communities?
I guess Sean, it's Derek here. I'll take a
Yeah,
maybe
sure.
shot from that, and others can add to it. I'll say that, you know, any temporary suspension of services in any of the communities out there, it's not that those aren't easy decisions, and mostly they're when we do disrupt services, it's as a result of staffing or not having the right available staffing to support a site. In this case, again, this wasn't an easy decision to make because we know that it has an implication for those communities. Looking at the overall situation that we're facing and the potential scenarios, we had identified a strong need to prepare and to be ready to have a strong defense strategy in place. I mean, if you look at what the experience that other jurisdictions have had, be it China or Italy or any European country that's managing this, New York, they've absolutely struggled with being overwhelmed, their health system being overwhelmed. I'm hopeful that that doesn't happen in Saskatchewan, but we need to be ready in case it does. And part of that strategy was to create spaces in our larger centers by converting these sites to alternate level of care temporarily, and also temporary suspending emergency services allows us to take those nurses and doctors that were working in those locations, bring them into those regional facilities and other facilities that are going to be supporting those kinds of surges. For example, getting them intubation training, getting them up to speed and working in an ICU to support ventilated patients. It's not an easy switch for a healthcare provider to jump from working in a community hospital emergency room to all of a sudden working in an ICU environment. We need appropriate time and preparation, time to do all the preparations, get them trained and oriented so they can safely deliver care, and we're ready. So again, I want to emphasize that that is a serious decision to make, as people have pointed out in the questions. But we believe that we're preparing for a scenario that we do see happening elsewhere where health systems are overwhelmed. So this is one of our strategies to be able to respond to that. Certainly the continued provision of emergency services to those communities will be delivered through other means, be through ambulance transfer and so on. So I do acknowledge the impact. I think it's important to remember the magnitude of the potential challenge that we're facing in all of this. Thank you.
Thank you. And we did just get one last question, and noting that we didn't have any questions for Alfredo, I will pose this to you just quickly. Many businesses have closed their door and many individuals have lost their job. Is the RCMP seeing an increase in crime, particularly property crime? And what is being done to address any increases, especially in rural areas?
Hello. We're not really seeing any increases in crime or property crime. Actually, our call volume seems to have gone down since a lot of the communities are participating in the staying at home guidelines. And as far as what we're doing, we've increased our patrols throughout our various communities that we police, and in particular the various businesses that are shut down. And yeah, we're not experiencing any rise in crime.
Perfect. Thank you very much. So that brings us to the end of today's Q&A. I just want to give each of the panelists a chance to share any final thoughts or any recommendations for communities of how they can best weather this pandemic and help out our vital healthcare workers to ensure that this pandemic comes to an end quickly and that our numbers in the province stay low. So I'll start with Dr. Krasnowski. to share some recommendations?
Sure. I think for me, my main message for you is to help us by helping each other. So I think the role that communities can play is by demonstrating community leadership, bringing people together in ways that respect the requirements to be physically distant, but not be socially distant from each other. So what are options to be promoting a community spirit and I guess a sense of solidarity at this time? I think there are opportunities to be thinking about people in the community who are really negatively impacted by the public health measures that are being put into place to protect all of us. So if there's a way that we can be connecting through volunteers, perhaps, to be supporting people who are socially isolated and do require a bit of help to support activities of daily living, such as doing grocery shopping, for instance, for seniors who may be isolated and at risk if they were to go out and have to do those things in the community themselves. That's just one option of ways that we can be thinking about supporting each other through this time. So I think we do need to be thinking ahead, and we do know that the measures that we have in place are really important, and they do need to be sustained, but they are difficult. So how can we make these days a bit easier for each other is something that I'm always thinking about, and I would encourage you to do the same.
Thank you very much. Next, we'll go to Patrina McGrath to share her final thoughts.
Yeah, I echo many of what Julie has said about, the community spirit in Saskatchewan is amazing, and really encourage us not to lose that and the support that we give. I think the other piece is just the continued vigilance of being able to ensuring that you're washing your hands, that you can maintain social distance, that you continue to do all the great things that you're doing to help us, really be on the offense on this. And then really as employers, as you work through measures to protect your own workers, how to do that and use, the appropriate measures and supports to protect them, but also really looking to our communities to where they don't need to use PPE like N95, and when it's not called for, to really ensure that we're using it right, so that our healthcare workers and our first responders who are really needing that level of protection have it when they need it. And that really takes all of us using it appropriately and following the guidelines in our day-to-day. So that would be keep doing the great work that you're doing already, and that would be my encouragement.
Thank you very much. Next, we'll go to Alfredo Bengloy.
Yeah, so for the RCMP, as far as we've taken measures to protect our employees and adjusted, like all police forces in the province, adjusted our service delivery as well. That's how we do things to respect the guidelines, public health guidelines, as much as possible. However, having said all that, we're still available to respond to any calls for service. And like all the other police forces in Saskatchewan, we're ready and available to maintain public safety in the province.
Thank you very much. Next, we'll have Evan Ulmer.
I guess I would say, and just to provide a bit of assurance as well, is the EMS team here is working hard. There's EMS located in 107 locations in the province, ground EMS and contracted operators, nonprofit, SHA owned and operated services, and we're all have come together in terms of working together and as part of the EMS Incident Command. Of course, as well, there's also our, as I mentioned before, Saskatchewan Air Ambulance Fixed Wing, STARS Rotary Wing, and then in the north, our basic to intermediate air medevac as well. So again, each area of the province has its own challenges, and there's challenges in the north, there's challenges in some other areas, but we're really working together with, again, our colleagues in facilities, acute care, and primary health to serve, ensure that patients will get the best response throughout this, both those that will have COVID and those that don't and have other emergencies as well.
Thank you very much. Krista Remichello.
Really, I think everything that Dr. Krasnowski already said pretty much caps off what I would say, and just the longer that we can stay on the offensive, the better we are. And yeah, no, just everybody stay safe.
Thank you very much. And last, Derek Miller, to share your final thoughts.
Thanks, Sean, and thanks for the opportunity to share these messages with the group today. I'll just very quickly say, you know, we have an offensive and a defensive strategy. We really need your help on the offense, and we can see Saskatchewan is already having success in that area just based on the numbers that we're seeing. We do have a defensive strategy in case we need it, and we're hoping we won't. But again, that'll be based off of the success on the offense. So we're all in this together, and again, appreciate you and your roles as municipal leaders or volunteers or whatever capacity that you are, you know, using that leadership to positively influence the people that you're around as you work on this together. So thank you all very much.
Thank you to all of our panelists today. This was a great opportunity to hear from the Saskatchewan Health Authority on what their recommendations are, and we hope that everyone has found use out of today's presentation. There's a lot of information available on COVID-19, and the municipalities of Saskatchewan is committed to supporting Saskatchewan's hometowns by providing access to the information and the resources that are important to you. We've created a hub on our website to help answer your COVID-19 questions and keep you updated. This hub includes information important to you as an employer, links to resources, including an infectious disease policy sample, and more. And I should note that in our COVID-19 weekly email, we will be sending out updates from the Saskatchewan Health Authority. That brings us to the end of today's webinar. Thank you all for your great questions. And I hope you take some time to fill out this survey to help improve our future webinars. Thank you again to all of our panelists, and we hope you have a great rest of your day.